Good morning, and you are very welcome to Menopause Matters, which is a coffee morning that's brought to you by Bias, Inequality in Women's Health and Research, which is a Research Ireland funded Science Week festival. It is Science Week, folks. And how fabulous is this venue? We're at the Pillar Room at the Rotunda Hospital. My name is Dr Caoimhe Hartley. I'm a science journalist, and it is an absolute pleasure to moderate a discussion about menopause here this morning with this super panel, and I will introduce them in a moment. But before we get started, let's just take a moment to figure out where the exits are in case we need to leave in a hurry. And also, as I mentioned before, just double check those phones are off. So menopause, it's a very interesting and sometimes challenging time in a woman's life. But I often think there's a lot that our mothers could not have told us about menopause. For one thing, there was a lot of secrecy and shame around the change when they were going through that change. And also, we just didn't know as much about the menopause from a scientific or medical perspective as we do now. Things are changing now. We do talk about it more, and science and medicine are approaching the topic with more gusto, helping people through this transition in life. This is actually the third event on menopause I've done in Science Week. There is a huge amount of interest in this topic, and I'm learning so much from experts in each one. And one of the things I learned this week that kind of blew my mind was that menopause is one day. It is the day that is exactly 12 months since your last period. Before that day, you're premenopausal, and after that day, you're postmenopausal. So it's just one day, and if you're not forensically tracking your periods, which probably get erratic around that time of life, then you might not know it's your menopause day. You could be wandering around Tesco, putting out the bins, sending emails, walking the dog, and not knowing that really you should be having a big cake that day because it's your menopause day. So that kind of blew my mind a little bit. But over to the real experts now. Let's say hello to our panel. We have Dr Caoimhe Hartley, who's a GP and who's with the Rotunda Menopause Clinic, and Dr Vicky O'Dwyer, who's a consultant obstetrician and gynaecologist at the Rotunda Hospital, and Dr Jillian Doyle, who's a senior clinical psychologist, again at the Rotunda Hospital. And I'd like to welcome our ISL interpreters as well. We have Amanda Mohan and Orla McCabe. And Amanda and Orla will be switching over every 10 minutes or so. Thank you so much. So let's start with thinking about that sort of development that I mentioned there, the way our mothers really couldn't have told us much about the menopause, and they had a very hard time. Caoimhe, what do you see as changing now about that?
I think lots has changed. Thank you for that introduction, by the way. It's nice to see everybody here, so good morning. Lots of things have changed. I think menopause was a bit of a dusty corner of women's health, which was a dusty corner of medicine for quite a long time. It depends what you want to look at. I think from a societal point of view and cultural point of view, there's been a shift in how we view aging in women in general. I hope for the positive, I think for the positive, and more of an embracing of the positives of aging and women's place in the workplace, that kind of thing, and less of a kind of negative attitude towards this transitionary time in someone's life. So there's a cultural shift, and I suppose an openness about talking about things that are previously would have been deemed too embarrassing, too private, something that you just didn't complain about, that kind of thing. So that's all a positive. Mm-hmm. From a medical perspective, there's been a shift in how we think about things too. Perimenopause, which is the lead up to your final period, which is your menopause, as you've mentioned. So perimenopause, where the hormones start to become a bit more erratic and change when women are actually often at their most symptomatic. That has been more talked about, more recognised even medically, and sort of it's now acceptable to say, I'm having these symptoms and I want to manage them if they're bothering me. We also, with the Women's Health Initiative, the big study that was done back in the 90s, that was published in the early 2000s, and that's kind of what led to this big scaremongering around hormone replacement therapy. That has been somewhat reanalyzed, revisited, walked back a little in parts, in elements, and has increased the options, I think, available for women to manage these symptoms if it's bothering them.
Yeah.
So there's been a few different aspects that have changed.
Okay, can I just go back to that study around the 2000s, because that was a big turning point, I think. And what came out of that was a message that maybe HRT was associated with increased risks of breast cancer. But, as you say, when you go back and reanalyze the data, that wasn't what the study was looking for, and the data didn't quite say that. So we've had a rethink on that. Can you explain that a little more?
So the Women's Health Initiative was enormous, is the first thing. So it was a huge trial looking at thousands of women. And there was different arms of the trial. They had some women who were on estrogen only. If they'd had a hysterectomy, they had other women on a combination of estrogen and progestin, which is most women that we would meet, because they still have a womb. The type of estrogen used in the study is an older-fashioned type of estrogen. It's one that we don't prescribe as much of anymore.
Okay.
Called Premarin, which is actually a combination of different types of estrogen.
So this is like old-fashioned medical estrogen.
Yeah, and actually the name Premarin is from pregnant mare's urine, because some of the estrogen, isn't that mind-blowing? So some of the estrogen that was in Premarin was derived from estrogen that was in the urine of pregnant mares. I mean, it doesn't matter where it comes from, really, if it's effective and it's safe. But, and it's also a tablet form of estrogen, which is slightly out of vogue now. We tend to prescribe estrogen through your skin now. And the type of progestin they would have used in that study was also an older-fashioned, I mean, it's still a progestin that we use, just not commonly in hormone replacement therapy anymore. And the average age of woman in the WHI was 63.
Right.
Average.
Okay.
Initiated.
And so to put that into context, when do most people experience perimenopause?
So again, it's just generalizing, because there is a lot of individuality with this, but from 45 onwards is when most women will start to experience some symptoms, and on average your final period is somewhere around 50, 51.
Okay.
But the study was designed to look at the impact of HRT on heart health. It wasn't designed to look at breast cancer. Now, we think there is a small increased risk of breast cancer with combination HRT, so you don't want the pendulum to kind of go the other direction, because that's misinformation too. It's not that there is no risk, but you have to contextualize the risk. You have to put numbers on it for women. We have to address the fact that what we prescribe now might be a bit safer, and a lot of the research points towards that too. And that's why that's why our consultations take 40 minutes, because there's a lot of nuance and discussion around that. But we've moved on from the WHI, thankfully.
Very good. Well, thanks for putting that into context and explaining it as well. Vicky, same question to you. What have you seen change around menopause, and both the attitudes to it and also what we're learning about it and how to manage it?
Well, I see a lot of women for all sorts of gynecology reasons. And one of the great things is that people are so open about talking about menopause or perimenopause now. So they might come and see me because their periods have changed. And we know that when you get into your 40s, 50s, your periods can become closer together, heavier, irregular. But as part of that consultation, people are now asking, well, have these other symptoms, and is it perimenopause? Is there something I can do about it? And I think it's really good to have that discussion so that people aren't silently suffering, that there are things that can be done. What I do say to women, though, is that HRT, it's not one size fits all. And sometimes the initial HRT you start on may not be ultimately the one you end up on. So we might change from a patch to a gel, or we might change from a progesterone tablet to a coil. And that you sometimes have to play around a little bit with the HRT. And the other thing is that it's not just HRT in isolation. There are lots of other lifestyle changes that can help as well.
Yes. Yeah, absolutely. And we can talk about that as well. But Jillian, I wanted to get a perspective from you as a psychologist. What have you seen change around menopause, both in attitudes and ways to approach helping people?
Yeah, I think very similarly to what the other panelists have said, I think there's been a societal and cultural shift in this country over the last number of years, and it's oftentimes women who are driving that change. And so women are perhaps being more reflective about changes in themselves and changes in the interaction between themselves and their culture. Perhaps in the past, women stepped out of the workforce at a certain point. And there's good and bad reasons for that. In a lot of cases now, women have to continue to work, but it also means that they're much more present in society and, tuned in and want their voices heard. There's obviously been a big shift in what we can talk about and what we shouldn't talk about. I think women are putting a huge value on their friends and having deep and meaningful conversations, and that's spreading out and spreading wider. I also think because now women are having children later, they're in the system. So, maybe historically women had finished having their children, in their 30s, whereas now people are having children well into their 30s, into their 40s. And so there's potentially less of a gap between having your first child and then finding yourself in perimenopause. And so you might be much more tuned in to the body, to what's happening in your body, and, more able to find comfort in the language around our bodies and what's happening in the body. So all of those shifts are important.
They're important and very welcome. It's funny the way you say now, we're more open about talking about it. As a woman in her mid-50s, I know if I'm talking to any of my friends of a similar age, you could almost set a timer and I'd say, give us even 60 seconds before we start to talk about something to do with menopause. So there is a lot of chat about it. But I suppose, going back to those symptoms, there's a huge spectrum of symptoms, from physical, emotional, well-being. Can you talk to me maybe about some of the more common symptoms that you see women coming to you about? Caoimhe?
How long do you have?
40 minutes?
Yeah, it's a long list, and it's a long list because it's really individual. So if you think of puberty, for example, and your hormones fluctuate a lot, particularly kind of in the early stages of puberty. Menarche, by the way, is the kind of bookend of menopause. So menarche is, like you're saying, your menopause is your final period that day. Mm-hmm. Menarche is the other end of it. It's the first one, exactly. Yeah. But anyway, with that kind of influx of hormonal change and fluctuations, we all know as teenagers we're all a bit different, and some people get acne and other women get really heavy, painful periods, and the whole kind of myriad of different symptoms. And the same is true of menopause. So it hits everybody very differently. And for some women, it's mood, emotional symptoms. We know that there is definitely increased risk of experiencing depression and anxiety around the time of the menopausal transition. There's biology underpinning that. Lots of physiological reasons why that happens. We'll also often see a lot of physical symptoms, so joint aches and pains. I think everyone is familiar with the concept of hot flushes and night sweats, and changes in your skin and changes in your hair. Some slightly less common ones like burning feet and burning tongue, weirdly enough. And then genitourinary symptoms of menopause. Bit of a mouthful, but essentially the bladder changes that we can see, like peeing more frequently, or new incontinence, or vaginal dryness, painful sex, that kind of thing. Okay. Like it's a very long list. Yeah. Okay. Or a mix of all of the above if you're really lucky. Yeah.
And I think another one that comes up a lot is sleep.
Oh my God, sleep. Yes.
Okay.
Yeah. Difficulty getting asleep, waking up in the middle of the night, and you're staring at the ceiling, and it's 3 o'clock, and you're thinking, I have to get up for work. And then it's 4 o'clock, and then you're exhausted the following day.
Right, and that has a huge knock-on effect, doesn't it? And if you are experiencing some of those other symptoms, they could feel worse because maybe you're a bit sleep deprived. Is that right? Yeah,
exactly.
Yeah. And Jillian, like from a psychological perspective, mental.
Yeah.
I mean, Caoimhe mentioned there that there's maybe a greater risk of anxiety and depression.
Yeah, absolutely. So people can experience more difficulties regulating their emotions. They might be experiencing mood swings. I think the impact of sleep on your mental health can't be underestimated. So, across the lifespan, if you are tired, you are more vulnerable. And that kind of disturbed sleep can really have a big impact on mental health. I also think that there can be feelings of shame around some symptoms. So for example, hot flushes, particularly if that's happening in a public place, that can bring on, an urge to kind of hide away. And that can, for some people, really kind of make things difficult or challenging. Some people experience cognitive symptoms, so brain fog. And again, if you're someone who it's very important that you're effective and efficient and you're a high achiever, that can have an impact on you. If you're experiencing changes to your skin, whether that's skin sagging or acne or hair loss, again, that's something that can have an impact on some people to a greater or lesser extent, in addition to weight gain. So for some people, that can be the straw that breaks the camel's back and really has an impact. Some people will experience difficulties with their mood, although I think what studies suggest is that sometimes the mood difficulties, because there's, I suppose, physiological components of mood difficulties, for example, sleeplessness, that can show up as, oh, this person has depressed mood, when actually it's not that, it's sleeplessness due to the menopause.
So it's all interconnected and one thing can blur into another.
Absolutely, yeah. But there is a risk of relapse for people who have had a depression at another point in their life.
Or maybe if there's a family history.
Or a family history,
yeah. That's something to watch out for.
Yeah, and that also makes sense given that it's a transition. It could be something physiological, but it can also just be that it's such a huge transition and challenge from a psychological point of view.
And that's whether you're going through menopause with the uterus, with the womb, or maybe it's after your ovaries have been removed or you've had some kind of treatment. So it's all a big change.
Yeah,
absolutely, which brings its own psychological challenges, I'm sure.
Yeah.
So let's talk about some solutions. I mean, the one that we hear probably the most about is hormone replacement therapy. So tell us about hormone replacement, because it's very complicated to somebody who's maybe just starting to look at this. So can you explain it? Can you break it down for us?
Yeah, I mean, we do start with everyone who comes in. I think it's important to individualize the options they have, but we start with lifestyle changes for everyone and what lifestyle interventions you maybe haven't thought of that can be impactful on your symptoms. We target sleep a lot, and we look at sleep hygiene, cognitive behavioral therapy for insomnia.
So can you explain what sleep hygiene is?
So sleep hygiene is really the kind of everything that surrounds your sleep. So the environment that you're going to sleep in. So you want a cool, quiet environment, reducing caffeine and alcohol, exercising but not too close to bedtime. And then really sleep hygiene essentially is going to bed at the same time every night and getting up at the same time every morning.
Right.
As late as you can, you want to go to bed, and as early as you can, you want to get out of bed, which is sleep efficiency. So I'm not saying you stay up till 3 a.m. and then go to bed, but you go to bed when you're kind of tired. I think a lot of people fall into the trap of thinking, I'm absolutely exhausted, it's 9 o'clock, I'm going to go to bed. And they might fall asleep by 9:30 or 10, but they're awake by 2 or 3 in the morning. And then reducing screen time, so turning laptops and phones. I feel like such a hypocrite when I say we're talking about these things. And reduce your caffeine and exercise. And sure, I'm sitting there on my phone at whatever time at night. But technically, turning off your laptop, turning off your phone, turning off the TV, doing something calm and quiet before you go to bed, etc. Like, very intuitive. I think most people are kind of clued into what is good or not good for their sleep. So we're trying to bolster your sleep and scaffold your sleep as much as we can. We do have very effective non-hormonal medications for managing a lot of these symptoms. Which I can elaborate on if you want, but it's, there's a lot of medical jargon around that. But essentially, the take-home message is we have options for women who do not want to or cannot take HRT.
Right.
And sometimes they're used as an adjunct to HRT as well. It's not one route or the other.
Both.
Yeah. So we have very good non-hormonal medications, and then we have hormone therapy, which is what you actually asked me about, I suppose. So HRT, the backbone of your hormone therapy is estrogen. Estrogen is the thing that makes you feel better. So whether you're perimenopausal and still having periods, or you're postmenopausal and your periods have stopped, it's estrogen that tends to be the most effective treatment for your symptoms.
Okay, particularly things like hot flushes.
Yeah.
I was smiling there when you were saying about it, because when a hot flush starts, there ain't no stopping it. You're stuck with it. So if you're experiencing that,
But estrogen will stop it.
Estrogen will stop it.
So it's
Yeah.
quite reliable at
Okay.
reducing the frequency and severity of hot flushes and night sweats. Its effect on other symptoms, as Vicky mentioned, is really individual. It doesn't fix everything. And so we don't really know until somebody gets started on HRT what their benefits are going to be symptomatically.
Right.
Estrogen also happens to be very good for your bone density, and it happens to be good for reducing heart disease if you are less than 10 years from your last period and under the age of 60. There's a little window of opportunity for that heart protection. Okay, so that's your estrogen. The second part of your hormone therapy, if you have a womb, if you have not had a hysterectomy, estrogen will cause thickening in the lining of the womb. That's a bad thing.
Yeah.
We give you progestogen, and again, as Vicky mentioned, that can either be in a tablet form for some women. Some people might use a Mirena coil to protect the lining of their womb while on estrogen.
Yeah.
And then you can kind of whisper, there's a third hormone called testosterone that's a bit more controversial, but wouldn't be considered a standard part of HRT.
Okay, but the standard, if you have a womb, you have your estrogen and your progesterone.
Exactly.
And if you do not have a womb,
for the most part, estrogen on its own.
estrogen on its own. Okay, great. Thank you for breaking that down for us. Vicky, can I ask you about the pelvic floor?
Yeah.
Because even a few of the symptoms that we've been talking about, things like, bladder issues, they can be very big for people who are experiencing perimenopause. And maybe it's one of those things that people don't like to talk about, but it could stop them running or exercising, or even, your kids are on the trampoline and say, Mommy, here, come have a go. You're like, no, thanks. So what can people do about that if they're experiencing issues with the pelvic floor?
Well, I suppose the first thing is, I think it's really good to have symptom checkers. So you can get them online and you just tick the perimenopausal or menopausal symptoms that you feel are bothering you. And then your treatment is going to be targeted towards those. So it might be that, you're on your HRT for your hot flushes, night sweats, you're on vaginal estrogen for some of those pelvic floor symptoms. Anyone can take vaginal estrogen. So even women who have a history of breast cancer, Vagifem, which is the common brand name that we use, or Vagirux, they are safe to use because they're topical and they're only acting locally on the area.
So they don't get into your entire body, they just work there.
They work locally.
Okay.
So I suppose the things that people would tell me is that, they have vaginal dryness, they have prolapse symptoms where they feel a pressure, like their womb is kind of falling down and they can't go for a run because they've got urinary symptoms, so whether that's a strong urge to go or that they're leaking a bit of urine. Or the other thing that's really common post-menopause is vulval symptoms. So a feeling of burning or discomfort or itching. And those can all be helped with topical estrogen. The other thing I would say is that physio is absolutely fantastic and can work wonders. So there's a small portion of women that will need surgery, and they're actually the minority of women for those symptoms. The vast majority, topical estrogen and a women's health physio can do wonders. The trampoline, I'm not sure. I think anyone who's had a baby, I don't know about trampolining.
Keep away from trampolines. And Kegel, I presume, you're talking about those exercises and just getting into you should be keeping up the habit, but if you've fallen out of the habit, get back into it. Yeah. And maybe every time you boil the kettle, do 10 of them, or every time you brush your teeth, or something.
Doing them now, Claire?
Do them now. Let's all do them now.
But the other thing, actually, is that the caffeine is bad for your bladder. So decaf tea, decaf coffee will reduce the urgency that you might have.
Okay, because it's a diuretic, so it puts your bladder under a bit more pressure, of course. And if you are on this localized estrogen, you don't need the progesterone with that one. You're only on that one. Okay.
And you can take that forever. So I'd have women into their 80s who are still taking it.
Okay, very good, thank you. And Jillian, from a mental health and well-being perspective, and this is where I'm talking about somebody who's maybe sort of on the foothills of just not feeling their best, feeling a bit subpar mentally. What can you do maybe that's sort of out there in the open? Are there things like, are there apps? Are there breathing exercises? What can people do for themselves?
Yeah, I suppose if you're beginning to feel that your mental health is being impacted, what research is suggesting is helpful is cognitive behavioural therapy, as Caoimhe has mentioned. There's going to be loads of apps for that. You can just Google them online. But the other thing that's really helpful is mindfulness. And there's some nice research studies coming out now about mindfulness for managing menopause symptoms. And there's different types of mindfulness. There's mindfulness-based stress reduction, which is about developing the capacity to be mindful. And really, mindfulness is just training your attention. So coming back to whatever it is that you're choosing to focus your attention on. So in people's communities, in secondary schools across the country, there'll be people teaching mindfulness-based stress reduction, or MBS, or for people who are experiencing mental health difficulties, there's mindfulness-based cognitive therapy, which is going to use some of the tools of cognitive behavioural therapy and kind of, I suppose, intersperse them with the mindfulness exercises to develop that capacity to watch where your mind goes. And then kind of, you know, for kind of general day-to-day things, keeping active. So some people will have maybe a yoga practice. Some people find being mindful of their breath really difficult, or doing formal mindfulness is really difficult. So for those people, doing mindful activities is the way to go. So as I said, a yoga practice. For someone, a mindful walk. If we've any sea swimmers here, that is the most mindful few seconds when you get into that cold water first. Yeah. But there's lots of different ways of cultivating that capacity to let go of the noise and tune into yourself.
Yeah, which is very important. You mentioned there physical activity, and we've already spoken about the importance of exercise, but not too close to bedtime. In terms of the better exercises to do at that time of life when most women go through menopause, we hear things like load-bearing exercise is good, resistance. Can you explain what are meant by those terms and why they're so good for women maybe going into their 40s, 50s and 60s? So load-bearing, resistance?
Any exercise.
Any exercise, okay.
Just as a baseline.
The best exercise is the exercise
Is any exercise, absolutely, yeah. It doesn't matter what you're doing. It doesn't matter if you're with a personal trainer. It doesn't matter if you're playing tennis with a friend. Like, just move. But I think, like, really you want a combination of aerobic exercise for heart health. So something that gets your heart rate up. And you want weight-bearing exercise for your bone health.
Okay. So by weight bearing, this is something where you're reminding your skeleton that you still need it.
Yeah.
So this could be running.
Walking
Swimming is not weight bearing.
No, it's great for your joints. It's great for your
in combination with other things.
Yeah, it's great for your heart, but weight bearing, I suppose, is anything where you're literally bearing your own body weight.
Yes, so, as I say, reminding your skeleton, we still need you.
Exactly, yeah.
Okay. And what about resistance training for the muscles as well?
Yeah, I mean, sarcopenia is something you'd see, you know, that kind of muscle wasting.
I think reformer Pilates ticks a lot of boxes.
Okay.
Like, you've got your resistance, there's a bit of weight to it. It's good for balance and stretching and joints. And you even see a lot of the rugby players now doing it in combination with their cardio and their weights. They're all doing reformer Pilates.
Yeah, I've never tried it. Do you do it?
Yeah.
Oh, cool.
Yeah. Okay. Only recently got into it.
I need to start doing some exercise.
But what's really good is popping up around the city. There's lots of these saunas followed by a cold dip in the ice bath.
I love that.
And they're just so good. There's one, I know this because there's one down the road from me in Old Belvedere in Donnybrook, which is not open that long, but it's absolutely brilliant. You just feel wonderful after it.
Yeah, and if you go with friends as well, just make it a social occasion. You can all have a good laugh. Yeah. Very good stuff. I suppose, you know, we've been talking a little bit about HRT. I do know that there have been a few issues with supply around some of the brands. Can you talk us through maybe, because that can be a scary thing for someone if they've been prescribed something and suddenly it's in short supply. So what's going on there?
Yeah, the patches have been, so it's really the patches is what we're talking about most of all, have been coming and going for the last 4 to 5 years. Intermittently, we'll get a few months where they're in great supply, a few months where they're short. It seems to depend on your pharmacy, what dose you're on. So Estradot is would be the most commonly prescribed patch, and then Everil is an alternative. We only had the 2 brands in Ireland for a while. Everil was a much bigger patch, and some people just preferred.
It's the German one. I've heard.
That's Estremon.
That's Estremon.
Yeah, so that's
I'm
more
not
recent.
on them, so I just hear these things on the way past.
So that has come in more recently to replace Estradot, which has gone short.
Okay.
I mean, the take home, I think, should be that these patches contain the type of estrogen that's in them is the same estrogen that we have in, there's 2 different products of gel, and then there's also a spray. So the difficulty sometimes is finding what suits you. Obviously, we're all a bit individual, and the difficulty as a prescriber is finding what dose on each of these things because they're not exactly equivalent.
Okay.
So technically a 50 patch is 2 pumps of gel, but kind of depends on the person and how you apply it, and so there's a little bit of tweaking that goes on, and that can be very frustrating if it's taken you a while to find the right dose of patch that really suits you, and then we have to change you. There's also nothing we can do about it, so we're trying to navigate around it as much as we can.
But there are options that as you say, there are different.
Always options.
There's a menu, and I think we're going to start seeing maybe more of a demand in January when we start to get the free HRT. We might see, that there's more of a pull on that supply as well. There's more of a demand on the supply. So.
Yeah, we need the manufacturers to ramp up.
You can navigate. Rest assured, we can navigate around it. Good stuff. I just wanted to ask you about workspaces and public spaces in terms of accommodating people who are going through menopause and maybe need that bit of extra support or access. What are your thoughts on that?
It's a difficult one. I think now that people are talking about it more, it's great. I think hybrid working is very helpful as well.
Yes.
And if you have a little bit of flexibility on your hours as well, so if you've had a bad night's sleep, that you can start later, finish later. Your environment is so important as well. So where is your desk within the office? Where are you in relation to the toilet if you've got bladder issues? Those kind of things that can be so important just to make little changes. I know here in the Rotunda we had an initiative where Caoimhe runs our complex menopause clinic, and there have been some appointments for our staff here. So I think, every workplace should be menopause friendly, but it's very much a work in progress.
Okay. But I suppose if you are in a workplace and you're finding you're not being supported, is the trick to speak up about it?
Yeah.
Or try and make your own accommodations in as much as you can, but get the support from your employer as well. Okay, very good. And public spaces as well. I mean, public spaces by law need to be accessible. Should they also be menopause friendly? Should we work towards that maybe as well? Yeah, absolutely. I wanted to ask you as well about menopause in maybe more marginalised communities, or maybe neurodiverse women, etc. What are you seeing there? What are the issues that you're seeing that people are facing, and how can we overcome them?
To any of us?
Yeah, any of you, yeah.
I mean, I'm definitely seeing more women being diagnosed with ADHD, which I think is really interesting. It's not my area specifically, but there seems to be some crossover of symptoms, maybe a little.
Okay.
I think that's really interesting as a kind of backdrop to maybe what's happening. And I think, for someone who is neurodivergent or has really any other medical issue in the background, it can make some of these menopausal symptoms a little more challenging to navigate, to cope with. And certainly for more marginalised groups, there's often barriers for them in terms of accessing not just treatment, but even accessing counselling, accessing the right information, accessing that educational piece around menopause too, which is.
Could those barriers be cultural, financial?
All of the above. I think there's some societal barriers, there's cultural barriers to how, certain cultures maybe view women's health, medical symptoms, aging, etc. And then financial barriers. The consultations often cost money.
Yes.
Waiting lists are long on a public system.
Yeah.
HRT is not free at the moment.
Not free at the moment, no. And also, if you need to be taking time off work to go to these appointments as well, that can be another difficulty. Yeah.
But we are seeing slowly things changing. It's something we've talked about in the Rotunda here, actually, is a reach out program for women who maybe are in a community where they might not as readily, access our service.
Yeah. Yeah.
And I know Karen Soff, she's a fabulous menopause doctor down in County Kerry, did a really amazing project where she did some research recently looking at the travelling community.
Okay.
And how they were bringing kind of information and education to them.
Oh, brilliant, brilliant. Good stuff.
I think some of the period problems that can happen around perimenopause can be quite distressing for people who are neurodiverse. And we see similar in younger women, particularly with autism, and that if their periods get heavy and prolonged, that's very distressing. And the Mirena coil is fantastic for that. Other things, like simple things like period pants, like what a good invention.
Yeah, I know. They've become quite popular in the last
Really
couple of years,
popular.
haven't they?
Yeah.
Yeah.
And then I think, the Rotunda has quite a varied population. We have a lot of disadvantaged women. And I suppose when they come into the system, for whatever reason, we try and look at all aspects of their health.
Yes. Yeah.
So if they're in one of our clinics because of their heavy periods, it may come up about menopause, and we try and be open with that discussion. We also have a number of doctors working with us from abroad. So we currently have a fellow from the Middle East, and what she would say is really menopause isn't as talked about there, but she's come here to learn about it and about the holistic treatment as well as HRT, and to bring that back to her own country.
Great, super, super. Jillian?
Yeah, like I think for people who are neurodivergent and have sensory difficulties, menopause can be really difficult. Like, if you think of some of the symptoms, again, something like a hot flush, if that's something that is really dysregulating for you, that can cause huge difficulties. As has been mentioned, for people who are marginalised, there are lots of barriers to care. And the language, as has been mentioned, can be quite complicated. And sometimes it can be hard to get interpreters, or people don't feel comfortable having an interpreter. Different cultures have different perceptions of the menopause, and for some cultures it can feel like a really difficult time because you're stepping away from this time of bearing children. But also, on the other hand, I think it's really important to say that some cultures deal with the menopause really well and haven't gone down the route of over-medicalising it and actually really value aging. And so there's something that, we can learn from other cultures and integrate that actually menopause is a normal part of the lifespan, and that, as women transition through menopause, they can begin to focus on other aspects of their identity and allow those to really flourish. So I think there's that kind of piece that we can learn a lot from looking outwards as well.
Very good.
So we would see a lot of patients in the complex clinic here who, for whatever reason, we're trying to avoid giving hormone replacement therapy. And we have this sort of list of medications that are helpful. Now, the SSRIs, SNRIs, so they would be antidepressants, anti-anxiety medications. They would be sort of top of our list for a couple of different reasons. They're really effective. So they're effective not just for mood and anxiety, although those things are often obviously an issue at the time of menopause for a lot of women, but they're really effective for hot flushes and night sweats.
Okay.
And I find a lot of women come in saying, I spoke to someone, I was told to take an antidepressant, and they're really confused, but I'm not depressed. Why was I given this medication? And it hasn't really been adequately communicated to them that actually serotonin, or one of the other hormones that these medications interact with and impact, is a hormone that also regulates your thermostat, just like estrogen does. So we can use these medications to help with the frequency and severity of hot flushes and night sweats. They're also helpful for sleep. Okay. They're really well tolerated, they're not addictive, and they're quite safe. So they're our preference. Okay. We have a few other hormones. There's a medication, or a few other medications. There's something called gabapentin, for example. There's another medication that's actually an overactive bladder medication called oxybutynin, which can be used as well for hot flushes and night sweats in particular. So as Vicky has mentioned, it's really depending on what issues you're coming to us with and what we want to target. In terms of sleep, we look at cognitive behavioral therapy for insomnia, sleep hygiene, all those other things. Sometimes we use melatonin, which in Ireland is on prescription. It's not a sedative, it's not addictive, it's not a sleeping tablet, but can be helpful for sleep, and there's some evidence to that through menopause. Sometimes the sedating antihistamines for short-term use can be helpful too. So we have a few different tools at our disposal. Mixed. I don't know why some women get a great response and others do not. But because the risk with melatonin is quite low, it is often worth a trial to see how someone gets on with it. Yeah. But it's not, just like HRT, it does not fix everything. It won't work for everyone. Yeah. So I suppose we work through our list as we go along. Yeah.
Thank you. I would see mixed with the melatonin. We try and stay away from sleeping tablets because they are addictive, and studies would say that there may be an increased risk of dementia later in life for people with long-term, who are taking long-term sleeping tablets. And you can also get that hangover effect the next day where you just don't feel fresh, even though you may have slept well.
Yeah. Thank you very much.
So it's good to know that we have that menu of options that can be creatively used to kind of weave around the HRT if somebody, for whatever reason, is not on HRT. That's good to know.
A great and frequent question, I have to say, that I have no satisfying answer to at all, to be perfectly honest with you. Like, we go by research and statistics and what we have, which is that up to 5 years of use, if you started in your 50s, for the majority of women, will provide them with more health benefit than risk. Now, at the 5-year mark, that does not mean that we go and wrestle the HRT away from you and leave you abandoned with your symptoms. What we know is that a lot of women won't need HRT for symptom relief for life, because your brain and your body will ultimately adapt to not having estrogen on board, even when you're on HRT, because the estrogen dose is low. It's more like a stepping stone, so we can gently withdraw that or taper it down for a lot of women and stop it quite successfully. But for those who need it for life, that's okay too. So what happens at the 5-year mark for a lot of women is just a discussion about, why would you stay on it? Do you still need it? What are your risks? What are your benefits? Where's your bone density at? What's your baseline breast cancer risk? Are you up to date with your mammogram, etc.? So it just becomes very individual after kind of 4 or 5 years. But we can broadly generalize in the first 5 years and say the majority of women get more benefit than risk. But it's hard, like it's impossible to predict who's going to need it for life, who won't, how long you should stay on it. It's very individual.
Okay.
And I think you could try and wean it. So let's say you're on a 50 patch, you could go down to a 25 patch, and if you notice a difference, then you go back up. You know, we're not just going to stop at cold turkey. I think people feel better for a number of reasons if they wean it down and then sometimes go back up and try again in a year's time.
Yeah, great. Thank you for that question.
Yeah, so women with high blood pressure, women with hypertension can go on HRT. So, I mean, hypertension is due to loads of different things. It's genetics, lifestyle. It's mostly genetics, to be honest. Genetics, aging, lifestyle, a number of other factors. But provided your blood pressure is well controlled, you can go on hormone therapy, but we limit you to taking the estrogen through your skin. It has less of an effect on your vascular system if we do that. Less likely that you have a clot, essentially. So we would prefer women with high blood pressure to take estrogen through their skin and to have normal blood pressure. So you can have a diagnosis of high blood pressure, have that blood pressure treated, and then appear into us with now normal blood pressure on your blood pressure medications, and that's fine. So HRT isn't really a treatment for high blood pressure, and nor is it a treatment for high cholesterol. It won't have an impact. Although oral estrogen, the tablet form, can drop your cholesterol, actually, interestingly. But because the blood clotting risk is higher, we tend to avoid it. It's not beneficial enough to your cholesterol. So Dermal estrogen through your skin will be completely neutral with regards to cholesterol, but neither of those things should preclude or stop you from taking HRT. You just need to be on the right dose and the right type.
Okay, okay, great.
Yeah.
Would you agree?
Yeah, and I think for cholesterol, obviously the first protocol is diet and exercise. And then there's lots of women on a low dose statin. And you might be on that and your cholesterol's well controlled and you go on your HRT. And then you can do your annual check where if your cholesterol is back down to normal, some women do come off their statin, but you have to keep an eye on your cholesterol thereafter. And often as part of a HRT consultation, it's an opportunity to look and see, is your blood pressure normal? What are your heart risks? Do you have a strong family history? What's your cholesterol like? And as Caoimhe said, have you had your mammogram? What's your breast cancer risk? So it's all about looking at women's health, because I think, as you get into your 40s, 50s, 60s, like, you're busy with life, you're looking after kids, you're looking after parents, you're working, but you need to look after your own health as well.
Great, thank you. A very relatable question, I think. Weight is a big issue for a lot of women around that time of life. So can you...
There's a couple of things with weight. So people often find it harder to lose weight, that they're gaining more weight, and that it's centrally distributed. So those things, we see them with other hormone conditions like polycystic ovarian syndrome, as well as with menopause. So yes, people will often go on a HRT and they'll find that they may lose weight easier or they stop gaining weight. Often there's other aspects to it as well. You become more active because you feel better. I don't think when people come off HRT, they notice a significant difference that the weight is going to pile back on. I don't know what your experience of it is.
I mean, we know that weight gain for men and women is very similar across the population from the age of 45 to 60. Menopause itself does not make you gain weight, but it may, as Vicky's mentioned, it may make you distribute that weight gain differently as a woman. So we tend to gain it across the middle, whereas men gain it in a more even distribution, I guess. But we change shape. So it's not just weight gain, your body changes shape, and that can be very distressing.
Yeah.
But the average weight gain across the population for men and women is actually the same. So a lot of it is actually being triggered by aging and genetics, not necessarily by hormonal change.
But back to the person's question, do you notice that when people stop HRT after that 5 years, does the weight change? Does it have an impact?
The research would suggest that for the vast majority of women, that HRT is quite neutral with regards to weight. So being on it or off it should make no difference. However, I'd put an asterisk on that and say there's always outliers.
Yes.
And some women who very much feel like they've gained weight on HRT and that weight gain improves coming off. For every one of them, I have one who is the other way around. But 98% of women are in the middle and it has no impact.
Okay.
So it's difficult to predict.
Yeah.
So the risk is related to the estrogen causes the lining of the womb to grow and proliferate, and it can overgrow and then become precancer cells and cancer cells. Your progesterone component should reduce that risk, and the risk will be lowest for women who have a Mirena coil. I spend hours every week seeing women who have bleeding issues on HRT. So their period had stopped, they go on HRT, suddenly they've got bleeding, or they've changed their dose of HRT and suddenly they've got bleeding. And for most of those women, it is HRT related. There is a very small percentage of women where they will have a precancer or a cancer. And that's often why you get referred into a gynecology service to have a camera test and a biopsy or a D&C done. The risk for women who have bleeding after menopause, who are on HRT, of having a cancer is lower than the risk for women who have bleeding after menopause who are not on HRT. So the overall risk is actually quite low, but it's not zero. So if you have irregular bleeding, you should see your GP.
Okay.
And it may be just you need an ultrasound scan, you may need to be seen by a gynecologist, and you're always better to have that check. And the other thing I would say is people worry when they come and see me that I'm going to stop their HRT, and I virtually never stop the HRT. Once the checks are fine, you either continue on the same one or we tweak the dose or the route so the bleeding problem goes away.
Great, thank you.
So I suppose the first thing to say is that women who have a surgical menopause, where they have their ovaries removed and the estrogen is suddenly gone, their symptoms can often be more severe and happen just so suddenly that it's much more difficult for them compared to some women who go through a natural menopause where their hormone declines and the ovaries may still be producing a little bit of estrogen, progesterone, testosterone. The bladder symptoms, I suppose it depends on what they are. So the things that I would often see women struggle with would be urinary urgency, frequency of urination, and getting up at night. Things like leaking when you cough and sneeze are related to the pelvic floor, and they are often related to childbirth, and menopause may also make those worse. So in terms of the treatments, as I said, your topical estrogens, women's health physio, looking at your water intake, so not overly restricting or not drinking too much, drinking less in the evenings, reducing tea, coffee, soft drinks, and alcohol can all help with the bladder. But ultimately, if those things haven't helped, it's worth seeing a gynecologist who has a specialist interest in urinary symptoms.
It's also a good question about resources and communities. So are there good websites and communities that people can go to if they want that to find out more information and get support?
We direct a lot of women to the Women's Health Concern, which is a UK website. It's the patient arm of the British Menopause Society, and it's full of really good patient information leaflets and information about various things.
Great.
We've recently established the Menopause Society of Ireland, and we're hoping in our 5-year plan to develop a patient arm that will be Irish-based and lead, direct people to Irish resources. So watch this space.
Good to hear, absolutely. PCOS, we mentioned this before, this is polycystic ovarian syndrome. And then endometriosis was the other one. This is where the lining of the womb sort of flares up and ends up in different parts of the body, etc. So can you talk us through how people with those conditions may experience menopause?
Well, I think endometriosis is a particularly important one because if you're giving someone estrogen, that can cause their endometriosis symptoms to worsen. So for women who've had a hysterectomy, we generally say they should have estrogen-only HRT. They don't need the progesterone. But the exception to that is women with endometriosis. They should have both, irrespective of whether they've had a hysterectomy, to prevent them getting symptoms that they may have had surgery for coming back again.
Right. And PCOS then?
Yeah, I think there's no huge amount of research looking at the impact of having previous diagnosis of polycystic ovarian syndrome and then what happens in terms of perimenopause and menopause. Some women with PCOS, their periods are irregular or not frequent. Not everyone, but for some women. And interestingly, when they come to perimenopause, their periods can actually become a little bit more regular, which is interesting.
Yeah.
And a history of polycystic ovarian syndrome slightly increases the risk of womb cancer, particularly if you're someone who had irregular periods and that was never really addressed. We sometimes just take that into account with how we treat the progestin, the dose, the type of progestin we advise. Outside of that, I can't think of anything majorly impactful, if you like. Yeah.
Okay, great, thank you.
like obviously that's hugely individual.
Yeah, I really...
I've seen sort of everything, so I'm hesitant to give it any sort of definite.
Yeah.
But again, if you're looking at statistics, some of it depends on age, and often women who come to menopause lose their ovarian function in any way, whether that's surgical or due to genetics and it's a natural menopause, whatever it might be. They're often women who have symptoms for longer, which is kind of a cruel trick of nature, that the earlier you start your symptoms, the longer the duration often. So that's not great news, I suppose, but we do have loads of interventions that are really helpful. And it is individual, so that's not set in stone. It really depends on you know, as a person and what happens this particular person sitting in front of you.
But the severity, you just don't have data on that, whether it...
Yeah, that should improve with time as well. Yeah, if you think of it like your brain essentially, if you have your ovaries removed, for example, or chemotherapy as an insult to your ovarian function, your brain is sort of hit with this shock of a sudden disappearance over a relatively short space of time of a very specific estrogen that your ovaries make, that your brain is kind of relying on. It's like a little, you know, worker bee going around your brain doing loads of things and then it's gone. Whereas with natural menopause, it's more like, it's not smooth sailing, obviously, but it's more like getting into the cold water gradually. And so there's a degree of adaptation happening slowly. So they're two very different things. But yeah, the same underlying issue, the same underlying mechanism of adaptation should be there, even if it's surgical menopause or abrupt menopause. Your brain ultimately should still be able to adapt to that, but it's harder.
Thanks. Sorry for the non-specific, well, not the non-specific.
So much about menopause is vague, and I live in a grey area, like in work. That's just where my comfort zone is. So yeah, very little about menopause is actually black and white, you know.
All right.
I think certainly with bone health, so let's say if you have a DEXA scan and you're looking for osteoporosis or osteopenia, which is the one before it, HRT can help your bones, but it's not a reason that we would necessarily prescribe HRT alone. So the other things, the weight-bearing exercises, calcium and vitamin D, and then there are other non-hormonal medications that women will often take after they've come off their HRT to prevent your osteopenia becoming osteoporosis. With, I suppose, other things like balance can get affected as we age. So we were talking about the reformer Pilates before, and I guess if you're unbalanced and you fall and you have osteoporosis, you're more likely to have a break. Whereas if you've got good bone health, you're less likely to end up with a fracture.
Great.
I mean, it's a difficult question, isn't it? There's no easy answer to that. I know exactly what you're getting at. Like, if it's so good for my health, why don't I just stay on it forever? But it's a balance of benefit and risk, I think. And I agree with Vicky, like from a bone point of view, it's undoubtedly, your bones are definitely more protected when you're on estrogen. It doesn't stop you from getting osteoporosis though. Some women can still be on estrogen, and because of genetic factors, there's other things at play with bone density. You can unfortunately still go on to develop osteopenia, osteoporosis. It's just one element in a bigger picture, but it does reduce the risk. But I think we're balancing that off against some potential increased risk as well. The research probably needs to get a bit more up to date and look at longer outcomes with women staying on HRT, but we can only work with what we have, you know, which is, as I say, you get to 5 years, it becomes very individual to look at what are your benefits and your risks with staying on HRT. We don't take it off you at 5 years. We just don't recommend that everyone stays on it forever, that's all. It's just a nuanced individual discussion.
Our bodies are truly wonderful, complex and adaptive individual things.
I think there are lots of reasons that people can feel like their muscles are fatiguing. What I'd say is it's usually worth doing kind of your baseline health checks. You know, are you anemic? Is your thyroid working normally? HRT may be beneficial. It can be linked with menopause. I think it's more classic to get joint pains and general fatigue rather than muscle specific, but it can be related. And then I think trying to increase your strength through exercise, maybe a particular course in the gym or physio that can help rebuild that strength that you might feel is reducing. But definitely a visit to the GP if you're noticing something that's new and different. It's worth doing an overall health check to be sure.
So I want to finish off by asking each of our experts for their top tip or top takeaway for menopause. Jillian, what would your top piece of advice be for people going through menopause?
I think that menopause is a transition, really important transition in life. And once you've got to menopause, you've navigated a lot of really important transitions. So to look at it perhaps as a point of challenge, but also, you know, an opportunity to explore and investigate, you know, new parts of yourself or parts of yourself that might need to change or alter in different ways. Relationships might need to change. Your view of yourself as a woman, your sexuality, there might be changes to that. But just to really see it as a transition point that will come and go, and that you will move through just as you have through all the others, and there's lots of support out there. And to think of asking for help early if you need that help, particularly, you know, sometimes we'll go and we'll ask for medical help early, but to ask for other sorts of help too, just once you start to recognize any signs or symptoms.
Thank you, Jillian. And Vicky?
I suppose one thing we didn't mention is the topic around sex, libido, relationships and menopause, which is huge. And people often ask me, because they come see a gynaecologist and they feel a bit more open in talking about it. But it is an issue for a lot of women, and it doesn't have to be. So simple things that you can do, you know, vaginal lubricants like Silk or Yes, which you can buy in the pharmacy, your vaginal estrogen, so if you have discomfort when you're having sex, that can improve by increasing the amount of estrogen that you have. And then with libido, a lot of women will find when they're on their estrogen and progesterone HRT that their libido may improve. And for some women, testosterone, which I know is talked about a lot, can be helpful, but not for everybody. And you know, an estrogen, progesterone, HRT may be just as good. The last thing to look at is what other medication you're on and what effect that's having on your libido. And just to discuss it when you come for a menopause consultation, feel free to be open about everything and talk about it, because there's lots that can be done.
Great, thank you. And thank you for bringing that up as well. And Caoimhe?
I mean, there's not much to add, is there? But I think there's loads of reasons to be hopeful and positive. And I think, you know, we've potentially got free HRT next year. We've, you know, these complex menopause clinics that didn't exist a few years ago. You know, we're doing this today. I just think there's loads of reasons to be positive. Women are asking really relevant and good questions, and that will push the research and science as well. So I think there's loads of reasons to be hopeful.
And thank you all for coming along to this beautiful Pillar Room. I have to say I'm quite nostalgic today, because I have a couple of personal connections with this room. This room is where my husband and I had our wedding reception almost 25 years ago. Yes, and my dad was the architect who restored it. So yeah, so I'm delighted to be here with you all. Thank you. So thank you to the staff at this beautiful pillar room. Thank you to Elisa and everybody from the Department of Obstetrics and Gynaecology at RCSI University of Medicine and Health Sciences, and all involved at the Bias Festival. Thank you to our sound and vision, to Blaze and Colm, for making us look and sound good. And thank you to our ISL interpreters, Amanda and Orla, who have been working exceptionally hard. And thank you, of course, to our fabulous panel, to Caoimhe, to Vicky, and to Jillian. Thank you so much. Thanks, everybody, and enjoy the rest of your day and have a fabulous weekend.